it's a three-part question, and it's about
Uh-oh.
the it's about the future, what you
Okay.
see for PAD treatment. Um, Over the next, say, 5 years, where do you see the technology going with what you're seeing in innovations now? Where also do you see the number of doctors getting more into this? Are there fellowships available to teach below knee uh, intervention? And also, do you see the vascular community becoming more widely accepted as far as this type of, or accepting this type of treatment?
I love that you are so knowledgeable about the big debate out there and the controversy over treating below the knee. And it's something that I know that you have intimate experience with several doctors, some telling you that they can treat below the knee, others telling you they can't. And ultimately, the ones that can actually helping to preserve your leg even longer. And, it's really important that the doctors do come into agreement as to what the standard should be for treating peripheral artery disease patients overall, not just above the knee, but also below the knee. I cut my teeth on peripheral artery disease treatments in one of the most advanced areas of the world, and that was in Italy with Dr. Marco Monzi and Dr. Mariano Polania. And that was in 2016 and 2017. And I had made, over the course of the time that I've been doing this, I literally have been to Italy nearly a dozen times to watch these doctors. And what impressed me the most was the fact that they could take these wires and balloons into the most fragile small vessels, clear into what's called the pedal plantar loop in the foot, small artery loop in the foot that feeds those toes. And it was interesting with so much experience and so much time over the years spent there that when I would come back to the US and I would watch some doctors and, and they would quit when they would get to the knee or just beyond the knee, the popliteal artery in the knee. They would get just through the popliteal and then they would leave the arteries below. And I would ask, I don't understand. You still have flow trickling to the feet. Don't you think that you should just kiss those tibials with a little balloon? Oh no, we don't do that. That'll just increase the risk of amputation. And I would say, but they do that all the time in Italy. And Dr. Marco Monzi and Dr. Mariano Polina, they have some of the highest success rates in limb salvage at more than 85%, with the lowest readmission rates in the entire region. So if they can do it, why are you not doing it here? And I started feeling like they were simply, some of these doctors were just arguing for their own limitations. Either they didn't have success at it because it does take some special skill on a lot of patients to go below the knee into those smaller vessels and particularly into the foot. Not just anyone could do it. It made me think that those doctors that weren't having success and saying that treating below the knee arteries was leading to an increase in amputations is that they just didn't know how to do it well. And they weren't, putting their egos aside and saying to some of the pioneers in this space, hey, you know what? Teach me. I want to learn. I want to grow. And so they just stopped doing it and they started putting out these studies. And that's why I take some studies with a grain of salt, because you have to look at who's doing it, what's the agenda, what's the skill set of the doctors that are in this study. And you could be the most fantastic speaker and world renowned with a great title at a large facility, well known, and not have those practical skills in every form or fashion, in every facet, of the vascular space. And yet they're the ones that are leading the charge in these studies and cherry picking the patients that they're going to include in the study. So you have to be very, very careful. I've seen with my own eyes, when I see those studies that say it can't be done, it shouldn't be done, it increases risk for amputation, I can only speak to experience. of being on the front lines, watching thousands of hours of procedures and following up with patients, sometimes, 6 months, a year, 2 years down the road, and now working through the way to my heart with many of you. We're now almost 5 years into this, and so many people that we worked with from the very beginning that were all on deck for amputation because the doctor said it wasn't possible to treat below the knee. And we were able to get them to an advanced limb salvage specialist who knows how to carefully take those and very cautiously take those wires and balloons, clear down the tibials and the perineal into the pedal loop in the foot. And these patients are still walking today. And it's amazing. You'd never want to go with a doctor that's going to do it all the time or do it too much. You really want to make sure that you are truly in need and your limb is in jeopardy when you do get that done. But I also argue that from my experience, I can only talk from my experience, and I'll have doctors that will come after me and probably criticize this video because I'm not a doctor. I can only tell you, being a journalist and being a trained journalist, I'm really great at observation. I'm really great at capturing the essence of what's happening and paying attention to details. And with my experience, the doctors were actually treating my camera as if it was a live case, as if they were broadcasting step by step the entire case from the moment they would puncture the artery, start sending in the wires and balloons and the contrast fluid and intravascular ultrasound. And so I learned a lot. I would take all of that video and I would listen to it, replay it for hours and hours, learn the lingo, watch replays of how they were navigating even the most complex lesions in the vessels and still being able to be successful and to restore blood flow. And so I feel like I have a unique experience. Some doctors have even said I've been in more cases with more doctors than they have. And these are some world-renowned doctors and that highly respect what I know and what we do. I will never claim to be a doctor. I will never, claim to know everything, and I could never do what they do. I can only share with you what I see. And what I see is the fact that it is possible to treat below the knee. It is possible to treat those vessels in the foot. It has to be when it's medically appropriate. That is left up to, that's where you're going to find differing opinions across the board. It's why we say to always get a second opinion, because the different doctors, different approaches, different tools, different techniques, different philosophies. And just because you trust them, because they're at a large hospital with a big name, it doesn't mean that they're the right doctor for you with the right skills. It's worth making sure that you ask the questions about their skill set. Are they more conservative in their approach? Do they believe in just going in, tiptoeing into the vessels, and a less is more approach? Only stenting when it's critical. Stenting is not frontline treatment. If a doctor says, oh, we're going to go in there, and they use the word stenting as if it is the treatment you're going to get, it's a red flag. Now, I'm going to tell you the exceptions to the rule. The heart, the aorta, the iliacs, usually pretty much guaranteed you're going to get a stent. But lower in the legs, when you're talking about blockages in your common femoral, that's at the bendy part, into the thigh, into the knee, below the knee, they don't know until they go in whether or not a stent might be needed these days. It used to be they would stent everything. Everything would get a stent. It just was part of the protocol. In fact, I was at a large hospital, and we went in and they were trying out a new device, and the doctor ended up saying, nope, we're not going to treat this patient. And we're thinking, well, why aren't you going to treat this patient? We just saw a similar presentation of disease at another facility just down the road. So why is it that they were able to treat it there and not here? And the doctor says, well, standard teaching protocols indicate that if you can't stent or we can't stent a particular artery, we can't treat it. So we send the patient to amputation. That patient did not know that just down the street, another doctor at a different facility, might not have been a well-known facility as this present facility that they were in, but a different facility that that woman would have walked out that day with her leg. And instead, she had her leg chopped off, having no idea. The doctor said she signed the document giving them clearance. If you get one of those documents when you go into a procedure at a large hospital that says, hey, I'm going to give, I'm giving you, the doctor, permission that if something goes wrong, that you can just, or we can't get through the blockage, that you can just amputate my leg. It is best to take a deep breath and maybe put a comment in there and say, I would rather be woken up to have the discussion. The exception being, if my life is on the line, whether I sign this document or not, if my life, it's going to be life or limb at that point, they're going to take your leg whether you sign that or not. So it doesn't matter. They won't tell you it doesn't matter whether you sign that or not. If you don't sign that, you at least, and I think, Alan, you know this, at least you have a chance to be woken up. You can ask the questions. You can make the determination. You know what? I want a second opinion on this. I want a different set of eyes on this. You might be an amazing doctor, the best in the world, but what if someone with a different set of eyes, a different set of tools, a different set of techniques might have a different trick up their sleeve? They might be part of a research study. Not every doctor is a part of every research study, right? And
Exactly right. I do remember we began our journey in trying to save my legs in August of 2022. And it took 3 different doctors to do that worked on me for the next 3 months. And I do remember that. And all of them had a different set of techniques.
And they don't have to be more or less, better or worse. They can just be different. I remember when I was following that FDA clearance process with that laser had the ability to get through 100% blockages. 100% blockages are the reason that people get their legs amputated in this case, right? If you have a 100% blockage, they can't get through it, then you're going to get amputated. If you don't have enough collateral vessels and you have wounds that won't heal, they're infected, there's gangrene, and your leg's cold, they're going to have to amputate. So what this laser could do is the laser could actually get through, I think they had a 94% success rate in getting through some of the toughest blockages. And so one hospital would have this laser, but one next door did not. Maybe one doctor in one facility would have this laser, but another did not. And they didn't know that this other doctor had this laser and was part of a study. So that's why it's so important that no matter what ails you, go and check with another doctor, and even say to your current doctor, say, you know what? I believe in you. I trust you. But what if someone has a different tool or technique, or is part of a study that neither of us may know about? And you were mentioning below the knee, which is how this conversation really began. There is so much happening below the knee. And those doctors that may not have felt the technology was available, or that their skill set was enough to be able to traverse those small, fragile vessels below the knee in the foot in a way that would be durable, I think you're going to see more and more of them giving in and saying, hey, you know what? Wow. I think technology has risen to a place where I think I feel more comfortable. And even doctors that might not have the best, finger skills to be able to navigate these vessels, they might have just an easier time with some different types of tools that might make up for where they fail with their hand skills. I know that I think, Alan, I think it was either you or our friend Douglas that had brought up in a previous conversation with vascular surgeon Dr. Devin Zarkowski out of San Diego, bioabsorbable stents.
Hmm.
And they're being tested, the ones that absorb right into your vessels. That those are even coming out, which may change people's ideas on stenting. It's a different type of stenting, right? It just absorbs right
Correct.
into the
I think
body.
they're being tested where in Europe right now. I believe so.
I think some of them might be cleared in Europe. Um, and I think that they're starting their clearance process here. So we'll have to get the company to come on to talk about what their path to market is for folks here in the US. But there are a lot of new technologies. There are even new roto-rooting technologies. The roto-rooting technologies, or what we call atherectomy, they're also evolving. They've been highly criticized because they get reimbursed at high levels, which happens with every newer device. But usually, I mean, I would think there would be a timeline in which when they price these new devices that come to market, they price it in a way that would incentivize doctors to try and use them. They say, hey, you know what? Here's a new device. It's cleared the FDA process. They have pretty good results. They want to incentivize people to try them. But sometimes that incentivization plan can be abused. And rightly so, some newspaper reporters have come out and said, hey, you know what? We're going to raise a red flag here to say that there are some people that are using these devices at 2 to 3 times the rate of other people. Now, there are some factors with some of the doctors that I've seen on the list of high users or high volume users of these devices. And I know for a fact that they just simply have more days in the cath lab. They're in very high risk areas with really highly complex patients, and especially patients that have below the knee disease. And so it does make sense that they might have a higher volume of usage. But I will tell you that I have been in cases where I'm not quite sure if the doctor's actually placed a device they've opened up inside the vessel, because usually with an atherectomy device, most of them you can hear the sounds, you get very familiarized with the sounds. If you've ever been in a procedure, you can hear,
Oh yeah.
you know, a couple of them are a little disconcerting. You're wondering, like, are you sawing off my leg
Like,
right now? What
like,
is
why is
really
my leg
happening?
vibrating?
What's vibrating?
Right.
And so it's really important with that. That's why we always say to patients, before you go into a procedure, don't just accept the fact that you're having an angiogram. There are a lot of questions that you need to ask, not only about skill set, but what are the tools you plan to use and why? Why are you using those tools? Do you take a less is more approach in treating my vessels? And what is your success rate? What are the contingency plans? What if you can't get through a blockage coming down from the top where they poke in the groin? Do you come up from below? Will you poke in to an artery in my foot, in my calf, or behind my knee and try and come up what they call a retrograde approach, coming up from the bottom? Because sometimes if they can't break through, these blockages typically have a cap on them, a hard cap. And if they can get through that cap, it might be more, the plaque below might be more amenable, and there might be a little pathway to get a wire. The whole key to these treatments right now, and actually why I liked that previous laser, the previous laser did not rely upon a wire guiding it, but every other device on the market right now requires that a wire actually be able to penetrate or traverse through a blockage or a narrowing in the artery in order to be able to treat. Now, sometimes they'll go into the artery wall, and that's what we call going subintimal, right? They're poking into the artery wall and they're creating a new channel. Those aren't typically as durable procedures as doing what we call going, true lumen or in the native vessel or in the main part of the vessel, but that's not always possible. And if they can try it to get blood flow and at least give you time, all of these procedures, every single one of these procedures to treat blocked arteries, it's temporary right now. And the goal would be is to make them more durable. And as we move forward and the technology I see coming to market now and over the course of the next 5 years, I think we're going to see higher patency rates, more durability. It doesn't mean that you as the patient should not be a partner in your program. You've got to do your part. With peripheral artery disease, there is so much that you can do to prevent and also to stall progression of this disease. So much. The medications, doing as prescribed, lifestyle modifications, and especially walking. I know it's easier said than done. And it's painful. But if you think about walking through that pain and with every single that hurts, that your body is responding with a new collateral vessel that is dilating and helping to reroute blood flow around that artery. It's that pain. You've got to say, you know what, thank you so much, for telling me that you are building my collateral network of vessels. And so right now, when it comes to these treatments, I like the less is more approach, if at all, if they're going to treat it all. First and foremost, always walking, always trying to see how far you can get first. But then saying to the doctor, great, you know what? I just need that much more blood flow, a little kiss of the balloon. Less is more, conservative is better. Tiptoe in, doctor, and just give me that much more blood flow so that I can walk further without pain, so that I can continue to build my collateral network of vessels. That's still your body's best protection against amputation, is those collateral vessels. We have people that have had their blockages opened up and then they close up a few months later or even a year later, and yet their test results for their ankle brachial index, that's the ABI test where you have the blood pressure cuffs on your legs and your arms, and they're still pretty high at 0.8, 0.7, clear up there. And that's really good. And it's because of their collateral network of vessels. And people ask, well, should I get treated? Because they're just scared that, well, what's going to happen, down the road? Is it going to get worse? Well, you know what? It may or may not. But at the very least, those collateral vessels are more likely than not going to sustain your leg if you can keep walking. At that point, when that blockage is there, you will have built all these collateral network of vessels, and you may not even need that main artery to live your life and to have a good quality of life. So, but I do think that we're going to see these angiograms, all these procedures actually become more durable over time. We even had patients that I've still followed up on from that laser from 5 years ago. Actually, gosh, wow, even more than that, 7 years ago on one of them. And one of them is in Canada. And this gentleman, he's been on our program before a couple of years ago. He was told by multiple hospitals in Canada and 2 university hospitals in Michigan that he needed bilateral AKAs, bilateral being both legs, AKAs meaning above the knee amputations. And he was able to work with us to get to the middle of nowhere in California that just so happened to have this laser device. And it was able to get through the 100% blockages in both legs. It is now, I believe, 6 years or 7 years later, he still walks 4 to 6 miles a day and has not had another procedure since. So it gives me hope that as we continue to attract more entrepreneurs in this space, greater innovation, you've got to incentivize these companies to innovate. You've got to incentivize these just new techniques. We don't have a cure until we have a cure for peripheral artery disease. We have to do more to incentivize not only the development of these devices, but the use of them. Now, that being said, there are always those cases that abuse the system. And the federal government does need to keep watch on those doctors and does need to crack down. We do need the watchdogs to say, hey, wait a minute. You're using these devices at 2 to 3 times the rate of everyone else. Are you just doing it for the money? Very important to have this watchdog scenario in those situations. But still, those doctors are the exception to the rule. I would argue that most doctors are really trying to do the right thing and are excited about the new technologies, are using them when medically appropriate. And I hope that the newspaper articles that have come out recently condemning, the innovation and the people using it and the pioneers in this space, I hope it doesn't deter innovation going forward. But at least for right now, I do have hope. I'm seeing a lot. I'm hoping to bring more for you next week. I'll make sure that we get doctors on that can talk about what they're most excited about in innovation at this next conference. So stay tuned for that. Did I
Excellent.
answer your questions?
Boy, that was a good one. That was a long question, wasn't it? Too many points. The reason I asked that was I'm experiencing a lot of that myself locally here. As you know, I just lost 5 of my doctors,
Wow.
and a ultrasound tech that has been taking care of me for 15 years. So with this new doctor in our local hospital, he's really fighting to get those devices so he can help more people. And one of those people is me. I need a laser. It's the only thing that will remove what I've got going on. Also, I'm seeing more acceptance in the local vascular field, even though my doctor is retiring. That doctor couldn't get through a blockage. He called on this other new doctor to, hey, can you do anything?
Mm-hmm.
And 2.5 years ago, my doctor, my vascular surgeon, was not real big on this type of treatment, the endovascular treatment of below knee. He was more of the, it's going to happen anyway. Why not just do it now while you're young so you can live with it?
Yep.
So even he's coming around, even though he's retiring. His wife was really into it and used it. I think worked on him a little bit. But yeah, just locally, I'm seeing some changes. And it's not a big hospital, just a little regional hospital. But I'm seeing some growth.
And I'm seeing the same thing. And you had asked, I think, in part 2, or was it part 3 of
Ooh.
your questions? We are seeing some hope coming out from the next generation of doctors. So many young doctors that are adopting and excited about the new endovascular approaches. We have this next generation that grew up with technology. They love technology. They embrace technology. Everything and anything, this Apple age of doctor that grew up with Apple, coming out with the new innovation every year and adopting the new phone every year, getting the new computer every year to 2 years. I think that they're going to be more amenable to new, more cutting edge approaches, techniques, and tools as we move ahead. We're already seeing that across the board. And it's really exciting. At this conference that I'm going to at NCVH, the new cardiovascular Horizons conference in New Orleans, they have an entire fellows track, which Craig Walker, who is the founder of this conference, allows me, and he'll escort me in and get me, set and introduced to the different fellows so that I can follow them on their track to being able to try out some of the demos of these devices. At one point last year, I had the opportunity to actually deploy what are called tacks, and it's a newer type of stenting device. It's more like a staple, so you don't have a full long stent. It's just this little. It reminds me of just a staple. You just deploy a tack to. So let's say you dissect a vessel where it peels back a piece of the vessel that's hanging down and blocking the artery. Well, they can go in and instead of putting a big long stent, they have a tack and they just pop it in there. And I was able to deploy one of those in a simulator. And so that was really fun. And it taught me, just that. I also had an opportunity to work with another device and learn how to use. It's from it now. Abbott owns it. It's a 360 device. It's a sander. It used to be from Cardiovascular Systems Incorporated. It's an orbital atherectomy device. It's like a sander. And I was able to demo one of those. I even had the opportunity recently. I haven't actually released those pictures, and it was last summer. I have had the opportunity to go down to UCLA's Lundquist Center, and they have a lab that was put together by David Chalian, who used to work for Philips. And it was a testing center, a training center for some imaging technologies. And I was able to go in and use the imaging device. Called ICE, and I was able to navigate it through a pig's heart. And it was incredible. It was such an incredible learning experience, but it was exciting to see these types of facilities popping up for fellows to be able to go in and go beyond their traditional textbook and university setting and actually get outside and have more hands-on experience in these labs with these devices. And so I think that that's really exciting. The one thing, and I think this also addresses, you were asking about the different doctors and accepting of the different practices. There are 4 different types of doctors in this space. Vascular medicine, whom I love. If you ever have a vascular medicine doctor that you can find to manage your medications, your lifestyle modification programs, they are fantastic. And some of the other doctors that are surgeons or practitioners, they also may have an extra certificate for vascular medicine. And so it's always worth saying, hey, do you have a vascular medicine credential? And we're seeing more and more. I think it was started by the Cleveland Clinic. And so they had offered a certification program for that. I really like vascular medicine doctors, especially for early stage PAD patients. Number 2, you do have vascular surgeons. Vascular surgeons traditionally handled PAD, and they were trained initially in open methods. It wasn't until there was a situation in Oregon where a patient, I think she might have been in her 80s, she had a blockage in her thigh, and the doctor said, well, we're just going to have to amputate. I can't get through it. You're not a candidate for bypass. And she said, I'm not going to have amputation. So this surgeon went to their interventional radiology department. Interventional radiologists at their core are literally groomed for using wires and other minimally invasive devices to go into arteries, especially for cancer patients. And they also perform minimally invasive procedures for dialysis patients and things like that. So the doctor said, hey, why don't you try using some of those wires and catheters and whatever you use for some of your other things to go in and see if you can open up this artery. And so the very first endovascular procedure on the leg was performed in Oregon at a university there. And what they did was they were able to size up catheter after catheter after catheter. So they just kept inserting a larger catheter and then a larger catheter and then a larger catheter to push that plaque aside. And they were able to open up this woman's vessel in a minimally invasive way. And that was an interventional radiologist. Now, then you have interventional cardiologists. They're also groomed and trained at their foundation in using wires and balloons to open up the most complex lesions in those tortuous vessels of the heart. And with the heart, that's a moving target. Imagine with the legs, it's a little bit more of a straight shot and the vessels are not moving, right? So you could imagine that these doctors that are navigating the heart would be appropriate to be able to also navigate those leg vessels as well. And so interventional cardiologists started getting into it. And in fact, they've been pioneers in minimally invasive procedures. I mean, some of the greatest technologies that have been created for minimally invasive approaches have been, including the balloon over the wire, have all been created by an interventional cardiologist. Now, there are a lot of interventional cardiologists out there. There are a lot. There are a lot more interventional cardiologists, but not all of them actually treat the legs, and not all of them I would want to treat my legs, because some of them, in my experience, in observing cases, treat the legs like they do the heart. And with the heart, you need to go in and you need to pump up that balloon hard and fast, quick, because if you keep that balloon opened up for too long, patient's dead, right? But with the legs, it seems like those vessels are a little bit more fragile. They're not moving. Leaving the balloon open for a longer period of time, it's not going to kill the patient. And so we have found that a lower inflation, slower inflation, and a longer inflation time seems to lead to greater durability. And so, we some of the interventional cardiologists need to adapt, to that as well. And they do over time. So if you do have an interventional cardiologist, it's good to ask them and say, hey, do you treat the legs like you do the heart, or do you adapt to a more conservative, less is more approach, making sure you use lower inflations, slower inflations, longer inflation times, and see what they say. It would be interesting. A doctor that you don't want is one that wouldn't answer that question. The doctor you do want is one that will say, wow, where did you learn that? Yes, of course I do this. Of course I use a less is more approach. Yes, that's better. Less chance of perforating or dissecting the vessel. When they pump the hell out of that balloon, what's going to happen? What happens when you literally blow up a balloon too fast?
Dissection.
Correct. It just pops. So you just think about it that way and understand the importance of choosing a doctor that has that less is more approach. Now, again, you have vascular medicine doctors, interventional cardiologists, interventional radiologists, and vascular surgeons. And right now, what we're seeing, and what you'll hear a lot about, and I get it every single day with our Leg Saver hotline with people calling in, it's with this, there's a turf war. And the practices hate when I call it a turf war, but you know what? Journalist at heart, I'm an observer, and I have to call it like I see it and I experience it. There is a turf war. And it's not about, they all want to say that their way is the best way. Their way is the only way. But the fact of the matter is, with the diabetes going out of control, 1 in every 2 adults being pre-diabetic, diabetic, and a top complication being peripheral artery disease, there are more patients than there are these specialists to go around, even with all of the practitioners combined. There aren't enough to go around. I have patients in North Carolina waiting for 3 months to even with lifestyle limiting claudication that are on the verge of quitting their job because they can't handle the pain and they can't do their job. And they can't get in to see their doctor to get a treatment for 3 months. And so we need all hands on deck. There is no time or space right now with what I'm seeing for any turf war. It is time for everyone to come together. And I want every one of you, if your doctor speaks poorly of another practice, I want you to say to that doctor, hey, can we really afford to lose even one doctor right now? Doctor, are you in that desperate need for patients? Is your dance card not full every single day? It took me 2 weeks to 3 weeks to get in here. If you're that hard up for patients, Well, then why couldn't I get in here the next day? We need all hands on deck, and we need greater standards. The American Heart Association and the American College of Cardiology and a bunch of the other societies all came together and have actually released some new standards, which I'm really excited about. Stay tuned over the next couple of weeks. I haven't wanted to talk about them because I don't want to speak out of turn until I talk to the doctors that helped to lead the charge in creating them. And we have that in the works to bring those doctors, and we're going to have doctors from every single one of those practices that are going to be present and showing you how their collaboration and their communication is leading the charge for the next generation of treatments for PAD, which also gives me so much hope. But as it stands right now, we have a shortage of vascular surgeons, and it's still the number one referral. So almost every single time unless a patient's already with a cardiologist or an interventional cardiologist for their heart, the podiatrists and the primary care always refer to vascular surgery, not understanding that other doctors within the hospital might have the same skills or a different set of skills that treats peripheral artery disease. But the fact is, we don't have enough vascular surgeons to go around. And I know some very talented vascular surgeons who I have literally flown patients across country to actually go see for very complex cases where they need a hybrid approach, where they need a doctor that knows how to do both endovascular and surgical technique. And they really needed that dual set of skills. But 30% of hospitals across the US have job postings for vascular surgeons. And especially in the rural communities, we have experienced one vascular surgeon on call for 3 to 4 hospitals within this 2-hour radius. And we had one patient unfortunately pass because that one vascular surgeon, she had an acute situation with clots in her leg, and the vascular surgeon was handling another emergency 2 hours away at another hospital. And we were able to help her coordinate to get a life flight up to UCSF in San Francisco, but it was a little too late. And so we need to have all hands on deck. We need to have a meeting of the minds. We need to have doctors actually just say, you know what, if I can't do it, and if I don't do it, it doesn't mean it can't be done or shouldn't be done, and be willing to give up the patient to other doctors and be able to collaborate and, again, have a meeting of the minds with other practices and just for the betterment of the patients, because as I said, we can't afford to lose even one doctor who has an interest in treating peripheral artery disease.